Excited to welcome on Cecilia Schowe. Now, Cecilia is a PGY2 emergency medicine pharmacy resident at the University of Louisville Health. You can find her on Twitter or X at Cecilia_farm. Cecilia, welcome. How are you doing today?
I'm good. Thanks for having me. Excited for this.
The excitement's all over here, and I hear you may be a music fan. I myself, think that I'm a music fan as well. So let the listeners know what's your favorite genre, or even do you have a favorite or notable concert you've been to recently?
Yeah, pretty big into country concerts. I think probably my favorite concert was Zach Bryan last year, so that was exciting.
Very jealous in the country realm. I'm a big George Strait fan, so I saw him. But I'll tell you what, Chris Stapleton stole the show. That was unbelievable. And I'm glad you said country. Little mini rant here that I said over the weekend to some friends. The people who say they like every music genre but country, you can't say that. You don't like every music genre. If you like every genre, you should be able to dip into all of them. All right. So typically complicated drug names go straight to the hemonc world, but that is certainly not the case with this semi-controversial reversal agent administered to some of our most critically ill. So take it away, Cecilia.
Yeah, thanks for the introduction. So like you said, today we're going to be talking about the use of Sugammadex in the emergency department. So to get us started, we're going to start off with a patient case regarding paralytic reversal in the ED that we'll circle back to at the end. So for our case, we have a 42-year-old female who presented to the ED after being life flighted in from the scene. According to medics, she has a past medical history of seizures, hypertension, depression. She had been in status epilepticus for about 20 minutes prior to their arrival. She was given midazolam 10 milligrams IM twice, and then given the inability to control her airway, she was intubated with 100 milligrams of ketamine and 120 milligrams of rocuronium, or about 1.2 mg per kg, and this was given 45 minutes ago. So on arrival to the ED, neuro presents to bedside and needs to determine if the patient is having seizures. So we'll circle back to this case here at the end once we talk about Sugammadex. So moving into some background, Sugammadex is a modified cyclodextrin structure. So it's essentially a ring-like compound that binds rocuronium and vecuronium by essentially encapsulating the drug and then therefore reducing the amount of rocuronium and vecuronium that's available to bind at that nicotinic cholinergic receptors in the neuromuscular junction, and then therefore reverses paralysis. Of note, this doesn't bind succinylcholine or any other neuromuscular blocking agent such as atracurium or cisatracurium. This was originally FDA approved in 2015 for the reversal of neuromuscular blockade induced by rocuronium or vecuronium in adults and pediatrics within the undergoing surgery. So while the use of Sugammadex in the operating room is relatively routine, but the use outside of the OR, specifically in the settings such as the ED and ICU, has gained a little bit more traction. So there are a variety of reasons we may need to reverse somebody's paralytic in the ED. Some key ones are going to be need for a timely neuro exam following a TBI. So given that we know rocuronium lasts for anywhere from 45 minutes to an hour and then longer with higher doses or impaired renal or hepatic function, we sometimes need a neuro exam quicker in these patients. Also need for a neuro exam in a patient that we're concerned for status or potentially even a can't intubate, can't ventilate type situation. The original FDA-approved dosing for Sugammadex was studied as a 16 mg per kg as a single bolus, following our single dose of rocuronium of 1.2 mg per kg, and this is for that immediate reversal that's needed within 3 minutes. So thinking about indications where this high dose might be recommended would be patients who just gave rocuronium to and then potentially have a can't intubate, can't ventilate type situation or potentially anaphylaxis development. The other recommended dosing recommendations are 4 mg per kg for patients that are considered in deep block, and then 2 mg per kg for patients that are considered in moderate block. So when thinking about dosing in the emergency department, a lot of our patients, we aren't necessarily going to be reversing right after they got rocuronium. So potentially using those lower doses might be appropriate. There's been a few studies that have looked at this, specifically in that post-operative and operative setting, look at kind of these lower doses. So 2 studies were originally published in 2023 and 2024 that were similar, that were looking at the use of Sugammadex for rocuronium reversal in the outpatient postoperative setting. These are both single-center retrospective cohort studies that included patients in this postoperative setting who received Sugammadex for that rocuronium reversal. They looked at primary outcomes of patients who had successful rocuronium-induced neuromuscular blockade, which was defined as an increase in train of 4 or progress note documentation. These studies included 34 and 39 patients respectively, and they had an average rocuronium dose of 1.07 mg per kg and then 1.1 mg per kg respectively. And they noted they found successful reversal of paralysis in about 74 to 85.3% of patients between the two studies, with an average rocuronium dose of about 3.4 to 3.6 mg per kg. They also noted no incidences of adverse events between the two studies. And then kind of the third study that was published here in 2024, this is evaluation of Sugammadex dosing for neurological examination in the emergency department. This is also a single center retrospective cohort study. And here their primary objective was to compare this low dose or 2 mg per kg compared to the little bit higher dose of 4 mg per kg for rocuronium-induced deep neuromuscular blockade reversal, specifically in the ED. They defined their outcome as successful rocuronium-induced neuromuscular blockade reversal by having a post-treatment train of 4 of 4. In this study, they included 24 patients, 9 in the low dose and then 15 in the high dose, with average rocuronium doses of 0.98 mg per kg in the low dose and then 1.2 mg per kg in the high dose. And between the two groups, they found there was no difference in reversal success rate between the two groups, and then also no difference in adverse events. So while all these studies are smaller retrospective studies, the data does suggest that these lower doses of 2 to 4 mg per kg of Sugammadex are likely appropriate for reversal in the ED setting for some of the indications we talked about. But then the question becomes, what did we do before Sugammadex, and can't we just continue to use that combo? So neostigmine was previously used and still might be the drug of choice in some hospitals for reversal, even in the OR setting. But neostigmine, it's a cholinergic agent that reversibly inhibits the enzyme acetylcholinesterase, which essentially breaks down acetylcholine and allows for its administration to build up at that neuromuscular junction and then overcome that competitive inhibition of neuromuscular blockade, therefore essentially reversing that paralysis. This is different from Sugammadex, which encapsulates the drug like we talked about, whereas neostigmine requires the body to kind of build up those concentrations of acetylcholine over time to overcome that paralysis. It's dosed at 0.03 to 0.07 mg per kg or a max of 5 milligrams with a peak effect of about 7 to 10 minutes. It does have some notable side effects due to its cholinergic side effects, including bradyarrhythmias, bronchoconstrictions or spasms, increased secretions, and nausea. And specifically to help combat these side effects, it's given in conjunction with glycopyrrolate, which is an anticholinergic agent, and its goal is to really help mitigate the side effects of neostigmine, specifically that bradycardia. And we give this at a dose of 0.2 milligrams per 1 milligram of neostigmine that's been given. Thinking about some specific populations where maybe I'd want to avoid this combination and favor using Sugammadex, so patients with a history of cardiovascular events or patients with high secretion burden at baseline, where this combination could lead to more harm. Of course, Sugammadex isn't necessarily free of side effects either. So some big ones to think about when administering Sugammadex. The package insert does note anaphylaxis and hypersensitivity reactions. The original FDA study reported the rates of anaphylaxis at about 0.3% following the 16 mg per kg dose. The 2023 guidelines by the American Society of Anesthesiology cited this overall incidence of about 1.4 per 10,000 patients compared to 0.3 in 10,000 patients with neostigmine. Some other side effects to note that we can see are bradycardia, which have been reported to lead to cardiac arrest, but a lot of our retrospective studies, those small patient populations have cited pretty minimal side effects of these adverse events noted. So while Sugammadex is more expensive, specifically depending on the hospital that you're at and the wholesale costs, it's roughly double the cost of neostigmine glycopyrrolate combination. It's likely associated with better reversal times and less residual neuromuscular blockade, and then potentially less side effects. I still think it's a reasonable option to use in the setting of emergent reversal. I think part of our job here as pharmacists in the ED and the ICU setting being that it is a controversial medication and a little bit more expensive, is to help pick the right patients where its use makes sense for our patients and is necessary. I think one way we can go about this is potentially the development of hospital guidelines or policies or just education to help determine patients who are going to be the most appropriate for use. I think some key things to consider if developing guidelines or policies or educations is having some sort of requirement that paralysis needs confirmed, with ideally a train of 4 if we're able. I know I've sometimes seen providers just assume that someone's still paralyzed if they haven't moved yet, and potentially ignoring some other reasons for that, like their TBI, that we're needing to reverse for in the first place. So just having that kind of conversation with the team. Also indicating a reasonable time frame that if this is passed, there's a very low threshold that the paralytic is still around, and then our Sugammadex wouldn't be indicated. So we know our half-life of rocuronium is anywhere from 20 to 70 minutes, which is prolonged in our renal and hepatic impairment, and just indicating a time frame where it's no longer necessary to give if that time has passed. And this can be something that's more of a case-by-case discussion with the team. And then also thinking about dose rounding. So Sugammadex comes in 200 milligram and 500 milligram vials. So thinking about like a 70-kilo patient, if we're thinking about giving a 2 to 4 mg per kg dose, this would be anywhere from 140 to 280 milligrams. And given we have that 200 milligram vial size, it would be totally reasonable to round up to that 200 milligrams to help prevent wasting of the drug when we're administering it, knowing we can always redose this medication. And then kind of the other big thing to consider, especially in the emergency department, is if we're in a situation where we reverse our paralytic and now the patient needs to be paralyzed again. This is, in my opinion, one of the reasons to use these lower doses of Sugammadex of this 2 to 4 mg per kg. If we do give these high doses of this 16 mg per kg, a waiting time of 24 hours is recommended just to ensure we're able to still reparalyze our patient. And then also noting some of our PK parameters are going to be a little bit different in these patients. So our onset of action of rocuronium is likely to be delayed by about 4 minutes and then shortened of upwards of up to 15 minutes. And then also in these patients, ideally, if we need to reparalyze them using an agent like succinylcholine, but knowing that there are some patients where it's contraindicated or not ideal to use succinylcholine. If we are going to use rocuronium again, and we're going to use that 1.2 mg per kg, we have to wait at least 5 minutes after giving that Sugammadex, and then knowing we could still see some of those different pharmacokinetic parameters. So to bring it back to our patient case, just to give a wrap up, we had a 42-year-old female with reported seizure activity for approximately 20 minutes who was intubated with 120 milligrams of rock, or about 1.2 mg per kg 45 minutes ago. Neuro's at bedside. They want to reverse this patient to help determine if she's still seizing and for proper administration of additional anti-epileptics. So if I was in this situation, the first thing I'm going to do is check a train of 4 in this patient. Given it's been 45 minutes ago, there's a good chance that she might not be paralyzed and may not need reversal. Come to find out, after checking a train of 4, she has 0 out of 0 twitches and is still paralyzed. I think given the data, Sugammadex having a little bit better side effect profile, higher rates of success with reversal, I think this would be a situation where reversal would be warranted and Sugammadex would be appropriate for this patient, given she has 0 to 0 twitches and the neostigmine really isn't indicated for deep neuromuscular blockade reversal. So in this situation, I'd recommend a 2 mg per kg Sugammadex dose times 1, rounding up to our nearest 200 milligram vial size. And if our train of 4 still remains less than 2 within about 2 to 4 minutes when Sugammadex is expected to work, we could redose her with another 2 mg per kg to get up to that 4 mg per kg dose. So then just bringing us to some take-home points and kind of a recap of everything we talked about. So Sugammadex is indicated for the reversal of rocuronium and vecuronium, specifically in the ED setting. This would be indicated for things like need for a timely neuro exam following a TBI, need for a neuro exam, and a patient concerned for status epilepticus, or can't intubate, can't ventilate type situation, or anaphylaxis development. There's been multiple small retrospective studies that have demonstrated that these lower doses of 2 to 4 mg per kg are likely appropriate. Some side effects we need to monitor and be aware for are things like anaphylaxis and bradycardia development. And then kind of the other big thing to consider is if we do have to reparalyze a patient, knowing we're going to see some different pharmacokinetic parameters if rocuronium is chosen to be used again, and then potentially using succinylcholine for these patients. And then finally, given that this is likely going to be an agent that's used in the emergency department, I think helping to make protocols or development of guidelines for use, or just having some education out there for nursing and providers on appropriate patient selection is going to be a key role for pharmacists to play with Sugammadex use in the emergency department.
Cecilia, that was awesome. The way you described that dosing was really well. I always refer that as the best fit dose if you're trying to do it to a vial, right? If you think about right that old Y equals mx plus b, you get that, and that feels like the best fit line there. So I love that. Now, also love that you emphasized um, it's a 20 to 70-minute half-life, but case by case basis. Because if anybody was at AEMP last year, there was a big case of somebody that responded at 4 hours after. So that definitely seems like the exception, not the norm. But I like that you highlighted that. Sometimes you have to remember patients aren't textbooks, and we got to think a little bit outside of those standard pharmacokinetics. Now, another question I think that has really come up and arose out of this getting used more in the perioperative space, where should it be stored? So I'm talking to an pharmacy resident. I want to get the EM perspective. So you did a lot of research looking into this, the data, why we use it and things. So in your opinion, what do you think it should be stored in the automated dispensing cabinets in the emergency department or not, meaning it's kept in the central pharmacy?
Yeah, I think that's a good question. I think administration obviously would love to have it downstairs, but I think personally it should be kept in the emergency department. If we're saying this is a medication that needs quickly for these patients to reverse them, especially in your can't intubate, can't ventilate type situation or anaphylaxis development, I think having to go all the way to the main pharmacy is definitely something that's going to take a little bit too long in this situation. So I think keeping in the ED is the best place to have it.
I couldn't agree more because one of the biggest arguments for using this is time, right? We're deciding what we're going to do with this patient or, and waiting, especially if we're trying to get this overnight or because these aren't happening right from 9 a.m. to 5 p.m., right? They're happening from 5 p.m. to 4 a.m. or something like that. So I agree. Now I think the other side of things, right? There's some administrative people being like, whoa, wait. And I think that if that's the concern, I think the what you would try to do is just watch your usage. And if you feel like, okay, we do have neurosurgery just grabbing it from the pics or whatever, okay, well then you go back and have another discussion. But I agree with your idea of keeping it in that dispensing cabinet. I also love the patient case highlighting its use in status epilepticus. I think most of us think of it in our TBI patients, right? Where they're trying to figure out what our GCS is, path weight, and et cetera. But I think this is a really unique indication, very common that could still very much happen that I don't think we think about as much. So, Cecilia, that was great. Listeners, let her know what a great job this was on Twitter or X at Cecilia_farm. But appreciate it. Thanks for sharing all your emergency medicine clinical pearl knowledge here regarding everyone's favorite reversal agent, Sugammadex. So fun to say. And you crushed pronouncing that like 30 times throughout. You definitely had the most complicated name out of any so far. So definitely give you your flowers there.
Thanks for having me on, Nick. This is great.